So to date, the data has suggested that in some instances, its only actionable mutations is maybe 10 to 20% at most, in which patients may actually benefit from precision medicine or actionable alterations like NTRK fusions or BRAF mutations, et cetera. But again, I think that's just the beginning. We're just at the beginning of this kind of era of defining cancer other than just by histology. And I anticipate, and I think many of us in the community anticipate in the next several years that we're going to see more and more of that. So that actual number of patients who may benefit from precision medicine or precision immuno-oncology may actually grow.
Because the activity of TRK inhibition has been tissue agnostic, meaning we're seeing responses in any TRK fusion positive cancer regardless of the origin or etiology of that cancer, I think that our testing practices shouldn't be biased toward certain disease types. Obviously, there are rarer tumors that are highly enriched in NTRK fusions like secretory breast carcinoma, congenital fibrosarcoma, mammary analog secretory carcinoma. And in those cases, we should be keen about testing patients. But I think for the other cases, hopefully we come to a point where physicians have the ability to order testing across a variety of different cancers to look for these rare events, because certainly when you find one of these TRK fusions, it can be highly meaningful for patients. And you have these therapies that can result in very brisk and durable benefit.
In reference to TRK fusions specifically, we really see two patterns in patients. There are certain rare cancer types which are almost defined by the presence of a TRK fusion and are therefore found universally. And those pertain to certain types of sarcomas or their adult equivalents. So tumors like infantile fibrosarcoma and other related cancers which we see in children, congenital nephromas, and then the adult equivalent of these conditions called mammary analog secretory gland cancer, which is a salivary gland cancer, or a so-called secretory breast cancer. So these are rare cancer types which now I think are going to be universally tested for the presence of TRK fusions in patients that have advanced disease or even potentially locally advanced disease, where these drugs might be used to actually downstage patients and allow more minimal surgeries. Then we have more common cancers, names of which we all know, like breast, colon, lung, and pancreas cancer or melanoma, that harbor TRK fusions much more rarely, typically in the order of 1 to even less than 0.5%. And in those cancers, it becomes a more challenging proposition to do a test to specifically and only look for TRK fusions, as opposed to a more broad next-generation sequencing test that could identify a much broader array of tumor-agnostic and tumor-specific biomarkers. And I think that's how we'll capture the majority of the TRK fusions in these more common cancer types where the fusion is a rarer event.
What's interesting that we've observed in both the phase 1, the phase 2, and the pediatric population is that even in the adult population, for example, that the patients who seem to harbor these NTRK fusions are younger. They tend to not have other alterations, driver mutations. For example, in lung cancer patient who does not have BRAF or ALK-ROS or EGFR, they're young and they're not a smoker, there's a chance that they may actually have NTRK fusions. And so those are some of those considerations that I've suggested to other physicians outside of MD Anderson to look for in those situations. We have a papillary thyroid cancer patient who is young, for example, who had no alterations, did not have your typical RET or BRAF alteration, but when we got the NGS, the patient had a clear NTRK3 fusion alteration and has benefited from larotrectinib and has been on the study for almost 2.5 years.